Your symptoms were real. Your appointment ended before anyone caught them. You followed every recommendation. You described what you felt. The visit moved on before anyone connected the dots because the system was never built to catch a vague, atypical signal in 15 minutes. A study in JAMA Internal Medicine tracked over 11,000 cardiac events across 47 hospitals and found women delayed seeking help because their early symptoms did not match the textbook list. The gap was not denial, it was design. In this video, I will show you which symptoms get missed most often, why short visits catch only the classic signs, and the exact way to describe what you feel so it cannot be dismissed. Her name was Linda Hargrove. For 3 weeks before her heart attack, Linda told her doctor twice that something felt off. Not pain, just a heaviness in her chest that came and went, and a tiredness that didn't match her usual mornings. Her doctor checked her blood pressure, looked at her chart, and moved on. He missed it. The appointment lasted 11 minutes. Linda's case is now part of a research record that most people never hear about. The gap between what a patient describes and what a short medical visit is actually built to catch. I'm James Reyes. I'm not a physician. I'm an independent researcher who reads the cardiology and internal medicine literature for a living, and I spend a lot of my time looking at the space between what patients say and what gets written down. Nothing in this video is medical advice. What it is the research your next 15-minute appointment may not have time to cover. Drop a comment right now with just your age, nothing else. I want to see who's watching, because what I'm about to show you depends on exactly where you are in this. Here's the thing almost nobody says out loud. The standard medical appointment was never designed to catch a vague signal. It was built decades ago around a different kind of visit, one complaint, one set of vitals, one decision. That structure made sense when most visits were about acute, obvious problems. It does not match what cardiac risk actually looks like in the body of someone over 60. And look, this isn't about, let me say this differently. This isn't a story about a careless doctor.
It's a story about a structure that was never given enough time to do the one thing it's supposed to do. Listen carefully enough to catch what doesn't fit the textbook pattern. The average primary care visit for a Medicare-aged patient runs around 15 minutes, sometimes less. In that window, a doctor is expected to address the stated reason for the visit, check medications, check vitals, and document everything for the chart. There's very little room left over for a symptom that doesn't sound like the ones taught first in medical training. That's the gap. And that gap between what heart research has shown for years about how heart disease actually announces itself and what's happening inside a 15-minute appointment right now is costing people the chance to act before it becomes an emergency. Linda's case, the way it appears in the broader research on this topic, isn't really about the heart attack itself. It's about the 11 minutes. 11 minutes to address her stated concern, check 2 boxes on a chronic condition she'd managed for years, and document the visit, with almost nothing left over to sit with a symptom that didn't fit cleanly into either category. That's not a story about one rushed doctor having a bad day. It's a story about a structure that has looked almost exactly the same for 50 years, applied to a patient population that has changed enormously in that same window. In my view, this is one of the most under-discussed structural problems in healthcare today. Not because doctors don't care, because the system was never built with enough time in it to catch a signal that doesn't match the script. When was the last time you described a symptom to a doctor and watched them move on to the next question before you finished explaining it? A study published in JAMA Internal Medicine, tracking more than 11,000 cardiac events across 47 hospitals, found that women, in particular, delayed seeking emergency care because their early symptoms didn't match the classic heart attack pattern most people, including many clinicians, were trained to look for first. That delay wasn't denial. It wasn't ignorance. The study pointed to something structural. The symptoms were real. They were reported, and the system's first filter wasn't built to flag them as urgent.
Write this down. The problem most people assume is my body didn't warn me, is, in a measurable number of cases, actually the structure around me wasn't built to register the warning. And there's a study published in Circulation, the Journal of the American Heart Association, tracking prodromal symptoms in women before a major cardiac event that shows exactly how deep this goes. That's where we're going next. 3 weeks ago, I went back through the original McSweeney study, the one that first put prodromal cardiac symptoms in women on the map, because I wanted to understand exactly which symptoms were involved and exactly how often they were dismissed before they were taken seriously. Published in Circulation, the McSweeney research tracked women in the days and weeks before a major cardiac event and asked them after the fact what they had actually felt beforehand. The most commonly reported symptoms were not chest pain. They were fatigue that didn't resolve with rest, disturbed sleep, shortness of breath with ordinary activity, and a vague but persistent sense that something in the body wasn't working the way it should. Almost none of these symptoms match the version of a heart attack most people have in their heads, the clutching the chest, collapsing to the floor image that decades of television and, frankly, decades of public health messaging built into our collective expectation of what a cardiac event looks like. If the symptoms that actually come first are fatigue and disturbed sleep, not chest pain, how would you know to mention them as a cardiac concern at all? Here's where it gets specific. The standard triage protocols used in most primary care and even some emergency settings were built around what researchers call classic presentation, symptoms that are easier to flag quickly in a short visit. Atypical symptoms, the ones the McSweeney research and later studies confirmed are actually more common in women and in adults over 60, historically carry less weight in that same triage process. Not because anyone decided they didn't matter, because the protocols were written before this research existed in its current form. Drop a comment if this is the first time you're hearing that fatigue and disrupted sleep can be cardiac warning signs, not just getting older. Carol Whitfield, 68, kept a private note on her phone for nearly a month. 3 lines. Tired again. Woke up at 3 a.m., couldn't get comfortable. Walked to the mailbox, had to sit on the porch steps after. She mentioned the tiredness to her doctor once, in passing, at the end of an unrelated visit. It didn't make it into the visit notes as a separate concern. 6 weeks later, she was in the cardiac unit. Carol's case isn't unusual. It's the pattern the research describes, a real symptom, reported, that didn't match what the system was scanning for first. When I was reading through this literature, the detail that stayed with me wasn't a percentage. It was a sentence buried in the discussion section of one of these papers. Researchers noted that women who experienced prodromal symptoms often described them to a provider before the cardiac event, and the symptoms were, in the researchers' words, not adequately addressed, not denied, not fabricated, addressed inadequately. That distinction matters. Not denial, just undercoded. That's not a footnote. That's the entire structural problem in 11 words. It's worth sitting with why this happens mechanically inside a short visit. A clinician working a packed schedule relies, consciously or not, on pattern recognition trained heavily around the presentation that's been emphasized for decades in both medical education and public health. Chest pain, radiating to the arm, sudden onset. That pattern is real, and it does save lives when it's present. The problem is that pattern recognition built around one dominant signal tends to underweight everything that doesn't resemble it, especially inside a visit too short to slow down and ask a third or fourth follow-up question about a vague complaint.
That's not a flaw in any individual doctor's training. It's what happens when a system optimized for speed meets a symptom that was never going to announce itself quickly in the first place. Before I get to the part that changes everything, the part that most videos on this topic get completely wrong, I need you to hold what you just heard about Carol and about the McSweeney data. Because the next study doesn't just confirm the pattern, it tells you exactly how long the delay in care actually was and why that number should change how you describe a symptom to your own doctor. Write this down. The delay in care isn't usually measured in minutes.
It's measured in the time it takes a patient to realize their symptom is being treated as routine and decide on their own to push back. A study published in JAMA Internal Medicine analyzed more than 11,000 cardiac events across 47 hospitals and looked specifically at how long it took women to seek emergency care after symptoms began compared to men. Women, on average, waited longer, and the research pointed to one consistent reason. Their early symptoms more often fell into the atypical category the previous study described: fatigue, disturbed sleep, a vague sense of unwellness. Symptoms that don't trigger the same internal alarm in the patient or in the provider that chest pain does. Here's the counterintuitive part. Most public health messaging about heart attacks has spent the last 20 years trying to teach people to recognize chest pain faster. That effort wasn't wrong. It saved lives. But it built an unintended side effect. A public that's now extremely good at recognizing the one symptom pattern that's actually less common in a meaningful share of cardiac events, and far less equipped to recognize the patterns that show up first, more quietly, in many women and in adults over 60. The myth most people walk around with is, if it were serious, my body would have made it obvious. The research says something different. In a significant number of documented cases, the body was specific. The signal just didn't get coded as urgent on the receiving end. Robert Castellano, 71, had a different experience, and his story shows the other side of this same structural gap. Robert's wife had read about atypical cardiac symptoms after a neighbor's health scare. When Robert mentioned, almost as an afterthought, that he'd been more winded than usual climbing the stairs to their bedroom, not painful, just winded, and a little more tired than normal for 2 weeks, she didn't let it pass as nothing. She wrote it down. 3 specifics, how many stairs, how long the breathlessness lasted, and that it was new compared to a month ago. At his next appointment, instead of saying, "I've been a little tired," Robert's wife had him read the 3 details off the note: specific, dated, comparative.
That specificity is exactly what moved his case from monitor and reassess to let's run the tests now. The same kind of symptom Linda described differently, processed differently, because it arrived in a form the system's triage process was built to flag. That's the mechanism, not a different symptom, a different level of specificity attached to the same kind of symptom. There's a reason specificity moves a clinician's attention so fast, and it isn't about being a better or more credible patient, it's about how triage actually works under time pressure. A provider with 15 minutes is, consciously or not, scanning for signals that are easy to act on quickly, a clear timeline, a measurable change, a comparison point. "I've been tired" has none of those. It could mean anything from poor sleep to a medication side effect to nothing at all. Winded after 12 stairs, which didn't happen a month ago, gives a provider something concrete enough to investigate within the same 15 minutes without needing a longer visit to extract the detail. That's not a workaround for a broken system. It's the one lever a patient actually controls inside a structure that isn't going to add more minutes to the appointment anytime soon. The structure of the short appointment isn't going to change before your next visit, but the way a symptom is described can change the moment you walk in, and that single shift in specificity is the actual point of leverage available to you right now. What would it take for you to describe your next symptom the way Robert's wife described his, specific, dated, and compared to your own baseline, instead of just saying, "I've been tired"? So where does that leave you? Not with a problem, with a decision. And I'm going to give you exactly 3 things to bring to your next appointment, built directly from what made the difference in Robert's case and what was missing in Linda and Carol's. Here are the 3 things to bring to your next appointment, built directly from what made the difference for Robert and what was missing for Linda and Carol. First, name the timeline. Not, "I've been tired." Instead, this started roughly 2 weeks ago, and it's been steady, not getting better, not getting worse. A provider scanning quickly under a 15-minute clock needs a start point before anything else.
Give it to them in the first sentence of the visit, not buried at the end after the blood pressure cuff comes off. If you can attach an actual date, even an approximate one, like the week after Thanksgiving, that single detail does more work than an entire paragraph of description. Second, name the comparison. Compare the symptom to your own normal, never to a textbook description you read somewhere, because that's not the comparison a clinician can act on quickly. I used to walk to the mailbox without stopping. Now I need to sit down halfway, and that's new. That kind of comparison is information a short visit can use immediately because it doesn't require the provider to guess what your baseline used to be. You've already done that work for them in one sentence. Third, write it down before you walk in and hand over the actual note. Not because anyone doubts what you're saying, but because a written, dated 3-line note moves through a 15-minute appointment faster than a verbal description does under time pressure. It becomes something the provider can glance at, point to, and attach directly to the chart, instead of something they're trying to remember and transcribe accurately while also checking 4 other boxes. This is exactly the gap that separated Robert's outcome from Linda's. Robert didn't have access to a longer appointment. His doctor didn't suddenly have more time that day. What changed was that the symptom arrived already organized into the 3 things a fast triage process is built to register. Linda's symptom was just as real. It simply never got translated into that format, and by the time anyone went looking for it specifically, the window for an early intervention had already closed. You are not a passive recipient of medical decisions. You are an informed participant in your own health, and the appointment structure doesn't have to change for that to be true. The 15-minute visit isn't going anywhere, but what you bring into it is something you control completely, starting with your very next appointment. 3 things in 30 seconds. The symptoms that come first for a meaningful number of people are not chest pain. They're fatigue that doesn't resolve, disrupted sleep, and breathlessness that wasn't there a month ago.
The triage process most short appointments rely on was built around the symptoms that are easiest to flag quickly, not necessarily the ones that show up first in your body. And the one lever you have available to you starting today is specificity, a dated timeline and a comparison to your own baseline written down before you ever sit down in that exam room. If you're walking away from this video differently than you walked in, drop "informed" in the comments. If this is the kind of research you want to keep seeing, the subscribe button is right there. I don't post every day. When I post, it matters. The next time something feels off, even slightly, what's the first specific detail you'll write down before your appointment, instead of just saying, "I've been tired"? I'm not your doctor. And honestly, that's exactly why I can tell you what your doctor might not have had the time to explain to you this week. Nothing in this video replaces an actual evaluation, a real exam, or your own physician's judgment about your specific situation. What this gives you is the language to make sure your version of "something feels off" gets heard the way Robert's eventually was, specific, dated, and comparative, instead of the way Linda's and Carol's almost weren't,
real, reported, and still somehow undercoded by a system that simply didn't have the minutes to ask a second question. Take these 3 things to your next appointment, not instead of your doctor, alongside them. That's how this actually works. Linda never got the chance to try this approach. Robert did, almost by accident, because someone in his life happened to write 3 details down. The difference between those 2 outcomes wasn't luck, and it wasn't the severity of what their bodies were doing. It was whether the symptom arrived in a form the system could move on quickly. You don't need a longer appointment. You need 3 sentences written down before you walk through the door. In the next video, I'm going to show you the specific lab and imaging markers most primary care visits don't order by default for a vague cardiac symptom, and why asking for them by name, using the same kind of specificity you just learned here, changes the entire conversation. It's one of the most underreported findings in this space. Watch it before your next appointment.